Welcome to our Facebook live chats on why surgeons and gastroenterologists need each other. We have a very interesting panel today. We have two gastroenterologists, myself, Henriette Heinrich, and Professor Bauerfeind from Zurich, and two surgeons, Ulrich Nitsche and Professor Fries from Munich. What we want to achieve today is a little bit of a controversial discussion on where are overlapping fields in gastroenterology and surgery, and I think we could start out by the senior surgeon and gastroenterologist explaining to us what hooked them to their respective subject and how their training went and how they came to where they were now. Peter, you want to start?
I should start? Sure.
Yes, please.
So I started my training actually as a surgeon, but my former chief, what was Professor Siebert in Munich, sent me to Zurich, unfortunately, and there I went into a gastroenterology department, and they asked me to stay, and that was 30 years ago. So you can see that was an easy switch. Within gastroenterology, at that time when I started, ulcer disease was still important, and then I did some research on Helicobacter, and I moved over to endoscopy, where I'm still doing today.
And maybe before we go on, just one reminder to everyone who is listening to our live chat. Please remember you can ask us questions anytime. We will have them here on our tablet, so we can bring your questions directly live into the discussion, and we can forward them to our experts.
Peter, I think we are very close, because my predecessor in Munich was Rüdiger Siebert, which was your first surgical boss. My name is Helmut Fries. I'm working at the Klinikum Rechts der Isar in Munich at the Technical University. I was trained as a surgeon first at the Ulm University with Hans Beger. Then I moved with Markus Büchler to Switzerland, to Bern, at the Inselspital for several years. Then I moved with Markus Büchler back to the Heidelberg University, and from there I moved to Munich to take over the chair of surgery as the successor of Rüdiger Siebert, your first boss. My field of interest is mainly pancreas and upper GI surgery, and of course the liver. This belongs always for me a little bit to the pancreas, and we have a good interaction with the gastroenterologists in Munich.
Yeah, we have a good interaction with the surgeons in Zurich too. I think there's still some fields where we discuss, for example, the cystic lesions in the pancreas, where we have some discussions how far we should go there. But over the years I'm working, it has really evolved in a good direction. And I remember when I started that Siebert was one of the first who did the cooperation with gastroenterologists. He was a little bit the founder of this cooperation, because he realized probably that they should work together instead of fighting too much, I guess.
I think this is always the case, but sometimes you need controversial positions to find at the end the right line where treatment is the best for the patients. And I think the cystic lesions, there was a time period where we did not know the disease so well, so we did maybe a little bit over treatment in many patients, then to become more conservative. And now we are still looking for the right timing in different cases when the patient should leave gastroenterology, move to the surgeon, and afterwards move back to the gastroenterologist.
Yeah, and I think the gastroenterologists actually, we learned, first we sent it all to surgery, and then we started to puncture them all, and now I have to tell my colleagues don't puncture them all because it doesn't help you. So it's kind of, I think that the gastroenterologists are overdoing it right now compared to the surgeons.
Yeah, I think we need interdisciplinary discussion of each patient. I think this is very important. And sometimes we are also controversial. Yeah. And I think this is also good. We have to fight for the benefit of the patient. And there, you as the gastroenterologist have your position, me as a surgeon as my position. And often it's then the situation, can we put a patient for surgery? Is his general condition good enough? And there I'm often surprised how many gastroenterologists are really thinking surgery is extremely dangerous for the patient.
Isn't it?
It's in part dangerous for the patient, but also intervention in gastroenterologists are mind dangerous. There you can also cause problems, and I think we should also lose the fear to ask our colleague on the other side, and as you are the gastroenterologist on the other side, that's what I mean, and get your advice on some cases. Also, when we have complications, to manage it together, it's all normally better than you know everything by yourself and you do everything by yourself. We have sometimes holds after the surgery. You have sometimes holds after your endoscopic intervention. And I think some patients are well managed within the discipline, but most patients are better managed by an interdisciplinary approach. And to taking there also the forces together. And there I think we have to lose the fear to talk to each other. I think this is very important.
So if I may throw a question in, when we look at a very general training aspect, would an ideal scenario in an ERB that a young surgeon and a young gastroenterologist evaluate a patient with abdominal pain together, would that be a good thing for the patient and also for the trainee?
I think in general yes, but you have always to see how to realize it in your hospital, because sometimes the two departments are very close together. Emergency room, maybe they are separated in a surgical and internal medicine one, I think not in an interdisciplinary way, and there you have to see how you can also from the logistic do this. Of course, if the patient comes with abdominal pain and the patient is seen by the surgeon and the gastroenterologist, it's always for the benefit of the patient, because two doctors look at the same problem and then they can discuss what is the best for the patient. But you need then also two doctors, and time in the hospitals is limited, so maybe it's a problem of this also.
So could training be, a structured training be a possibility? So gastroenterologists have a structured part of their curriculum where they go into surgery to understand the problems of abdominal surgery complications, and surgeons coming into gastroenterology to learn about gastroenterological management and endoscopy from gastroenterologists. I think that would be a very, very interesting approach, and I would be very interested on your thoughts on that, because we both had so many crossroads with the respective
We don't have it yet, but I think in principle it's good, and there are some units like the one in Bern, how it is now, they are basically together. So the residents are sharing on the ward surgery and internal medicine. That might be an option to collaborate. I think.
Do you think this could be the future, to have some such interdisciplinary units, or do you think the future would rather be that every discipline is even more splitting up?
It looks a little bit, so in Basel we have the same situation. Visceral surgery and gastroenterology are one department. Bern, they have established it. We as gastroenterologists are a little bit afraid about the surgical chiefs, because they tend to be more trying to get hold of everything.
to ask at the end the question, who is the boss here?
You could tell it this way, but
Is this
what
what
do you mean? Yes.
Is this what you are trying, Professor Fries? Trying to get everything controlled, or do you think this is not the...
I think this is not the future. I think we have to join the forces together, but of course there are many concerns, and if a surgeon and a gastroenterologist are working together, a lot is trust. Yeah. This is the beginning. And if there is trust between the two bosses, then also for the co-worker it's much easier to collaborate. And I think a lot of personal contact is especially important, because if you know people on a personal basis better, things are going much easier. You call him, you ask him, he helps you if you have a problem. And I think this is often not the case. Yeah. So everybody is developing in his own clinic, and too little interaction. And I think the boards, what we meanwhile have for cystic pancreatic tumors or interdisciplinary tumor boards, where we discuss, this brings already people together, and I think this makes things also less complicated.
Yeah, absolutely. And I think one important question with this is number of cases. I give you an example. If you don't have enough number of cases, then you tend to keep them for you. So, for example, if I don't have enough mucosal resections, I would rather do more or overdo the mucosal resection indication instead of sending them to surgery. Or if the surgeon doesn't have enough pancreas, he would rather try to operate things what they don't. Do you agree?
Yes.
So I think it is a little bit linked to the question of centralization, of having good large units where everybody has enough work, so they are not forced to take away things what shouldn't be taken away.
And
do you agree?
Yes, and I think also the other thing is the financial regulations in a hospital.
Yeah.
Because if the financial situation is that everybody should run for his own and is looked for his own, I think everybody's running for his own and tries to make the best to fulfill the criteria which are expected from the management. Or if the incentives are set differently, then the development is differently. And there I think we need also a good system. This is with interdisciplinary wards, for example. I think in Germany there are also some clinics where they have tried it, but then it's always financial aspects. He provides too much deficit, we bring the money, and this is then the fighting at the end. Is it good or bad? I think for the patients they can take advantage out of this. But this has also to be the will of the hospital management. And unfortunately, at least in Germany, the bosses of a department, they are very much dependent on the management nowadays. This was easier before, where the bosses have more power, but at that time the collaboration was not better.
No, it was not better, that's true. But we learned, I think we learned a lot. And I think the surgeons and the gastroenterologists really grew together during the last 20 years. That was a big adventure. Then coming back to the question of training, I'm thinking of that, but I think in principle it would be good to have an exchange. Not completely, but in a certain way.
So maybe also trainees who are interested in interventional endoscopy, that they learn about surgical techniques as well, from that technical aspect?
Yeah.
Or just for understanding?
Practically, I think it wouldn't be bad if someone who does endoscopy or does gastroenterology spent, I don't know, 6 months on the surgical ward and the surgical intensive care and the surgical emergency room in order to see how they behave, what they see, what they do. That would certainly help.
I think it would help if this would be included in the educational curriculum.
Yeah.
Because many young people come, they want to become a surgeon or they want to become a gastroenterologist, and then they are really focused on fulfilling all the criteria to get their specialization in this field. If there is then a turn, let's say 1 year or 2 years in surgery, it's lost time for them. So in their curriculum, this is some extra, it's always good, but it does not fit in the curriculum which is coming from the Ärztekammer, the medical board. It gives finally the certificates. And I think if this could be included, I think it's worthwhile. Yeah. Everybody would take benefit out of it, and I think it would also improve the quality of management for the patients.
So beforehand you said it's good if the surgeons and the gastroenterologists know each other personally, then you can discuss something on a shorter way. But do you think maybe it can be too close to personal? So for example in an interdisciplinary board, maybe it's good to have some fighting, some discussion, maybe they should not everything be on the same level, but we need to fight a little bit so that we really can bring our ideas and our treatment to the patient? Or do you think we don't need this?
I think we need always some controversy, because if everybody is agreeing on something, there is no movement and no improvement in the treatment. But it's sometimes principles. You see that one position says, I want now this patient operated, and until I have reached my aim, I will never give up. Also, the arguments of my colleagues are very good. I understand them, and yes, I can also say, okay, we wait for 3 more months and do a control, but then you are a little bit like this, and this is then blocking a lot.
So we should break
And I
down
think
so
this is the problem.
Yeah.
But if you have a good relationship on a personal basis, you say then operating, or let's try him to do it endoscopically, and if he fails, then we do the resection, or if he does a perforation because it goes relatively deep, then I don't make a big story out of it. Then you call me and say we have a hole, I say send him in the operating theater, the next day it's fixed, and we explain it together to the patient. This can happen and everything is fine.
Yeah.
But this is then the fight that then, if you make a perforation, the surgeon in former times, not in us, says, oh, this was too much for the gastroenterologist, so he made a hole, it's horrible, but I saved your life at the end. I think this time should be over.
Sorry to interrupting you, we have already some comments. Some people write, they think it's a good idea that we have that at least some weeks of changing the disciplines may be good for the trainees. And here's one question, they say, maybe interesting, what has been your worst gastroenterologist surgeon fight about? And vice versa, what has been the most beneficial situation? So maybe both of you could comment if you remember something.
Oh, that's a good question.
That's a very good question. My worst with the surgeon. Well, it all depends, of course, on the surgeon, and I can't really name the one I'm thinking of. But usually this is exactly when communication was bad. Because then it was, the worst thing I remember was that I was the opinion that we shouldn't operate. It was a Whipple at that time, and the surgeon said it was, and we both informed the patient. So it was not a clinical worst case, but it was psychologically simply completely wrong that one says the opposite of the other one. That should not happen, because then the patient in the end you will lose the patient. He will left the hospital if he understands that they are not collaborating.
So again, we're about talking to each other.
Yeah. So it all depends on that position. You need to be together, otherwise it's not working.
I think the worst is always when you get information from somebody, and then if it's related to your colleague, you don't take the telephone and call him personally. And you think he has done it because in some intention he told the patient he does not need a surgery or whatever. It's better than to call him, and this often we don't do. If you don't do it, then you have your own ideas, and this makes emotions and other things. And if you call him, he tells you this is the reason, and you say, okay, I understand, accept, wonderful. So I think too little communication is often a problem.
And what I always observe you doing, what I try to copy, is when I have something, a large carcinoma or something, that I try to call the surgeon on call or someone I know who does the lower GI surgery to see the tumor right away. And I think this is something that helps immensely. It takes up a lot of time because someone has to come to the endoscopy suite, but that's also something we do. We come to the operating room to show an anastomosis or to put in a sponge. And I think these short, direct communications are very beneficial for the patient. These are informal.
Actually, this is exactly one question that another user wrote. He said, I would suggest, it seems he's a gastroenterologist, I would suggest that our surgeons do not need a gastroenterologist next to them in the operation theater. Similarly, I would suggest that we don't need surgeons in our endoscopy units.
I don't agree.
Actually, the opposite of what you are saying.
No, I don't agree, because this is not only because you have to see what others see, but it is also the way to communicate. If we have a rectal cancer freshly detected, I'm calling the colorectal surgeon to show him the cetus immediately. He knows the patient. It's not only the cetus, it's not only what we find, it's because in this moment we start to talk. And I think a good surgical chief, what I have done, for example, for the esophagus surgery, he always takes his OBOS or his resident with him, so they already get used to it. So go to the gastroenterologist, let it show to him, and he calls me for the operation room. Of course I can't do anything. what can I do? But it still keeps the communication open. We see the problem of the others. We see how they struggle. It's very important.
I think important in hospital buildings is that there are short ways. Because in many hospitals you have to run for a kilometer to go to your gastroenterologist. And of course this is a limitation if he calls you maybe to just jump in to speak to a patient and so on. And I think this should be always possible. And I think it's good if a patient is sitting in our hospital in gastroenterology, my colleague Roland Schmidt is calling me, says, I have somebody, I think he needs surgery, can you come or can somebody of your department come and explain to the patient what kind of surgery is done, and if it's possible, if somebody is free, he will go there and speak to the patient, and the patients are grateful for this.
I think it's also very important from the patient perspective, because the moment we, for example, detect rectal carcinoma, we have the gastroenterologist and the surgeon in the room, something starts to move for the patient. And I think that also shortens waiting times. And I don't think it rules out interdisciplinary discussion at all, but the main pathway for the patient has been chosen in a very short time frame.
Yeah,
and I find that very beneficial.
That is one point, and the other point is frequently the patient, let's say you treat a patient and then you tell them, well, I send you to the gastroenterologist, and frequently the patient, it's not you doing it, so who is doing it? So if I have time and if it is possible, the 5-minute contact, so this is the person who will treat you further. So it's of course more important the other way, because if I tell a patient, this is not easy to do, you need a big operation, then they are massively afraid. If I can show him the surgeon, like this is the person, look at him, he's okay. Then the next step is so much easier than if I send him home, he's sitting at home and wait for a letter to be invited, I have to go to this professor, I have never seen him. It's a completely different situation. So it may take 5 minutes, but that helps enormously.
Yeah, that's true. That's true. Also, when we see patients and you send them for gastrointestinal oncology, it's always good if the gastrointestinal oncologist is then coming, speaking to the patient, answering all the questions. This relaxes the patients very much.
Yeah.
We have been really, really harmonious, actually.
It was bad.
We are really not. Maybe
we are already too senior and have seen so many things and have learned also for ourselves how to make it better.
No, but what I wanted to throw into the melee, because I think it's an important point for the young trainees, that there are still some gray areas, like pre-malignant lesions, where the gastroenterologist starts to cut, and where surgeons might not be too happy about it, because that's always a discussion. And I think there are more and more technical ways endoscopically to manage these lesions, and there's in many areas that there's a growing pool of data, but not enough. And I think there's still some friction there, and I think it would be very interesting if you two could comment on that a little bit, because that's still slightly common.
Yeah, I mean, when we said we talk to each other, then we talk to each other. That doesn't mean that we're always the same opinion. Of course not. It's impossible, and you have frequently situations where you don't know really what is the best, and then you have to, in the end, decide. And it might not be the decision I take or that you take. So if you wanted an example. The cystic lesions, I think, is really a good example, because we frequently do not have the knowledge to decide. So we have to decide on our own gut feeling, and then the other, of course, suddenly thinks, oh, I'm not sure. He wanted that, and I don't. We'll see what comes out, and I remember. Then, of course, operation is done. We recently had a case, and the resected part of the pancreas showed no cystic lesion, none. Yeah, and I have a very good relation to my surgeon.
I think we have always a lot of controversy where evidence is missing.
Absolutely.
And for the cystic tumors, it was a new disease. And of course, we were very concerned about malignancy and to prevent malignancy. On the other side, the gastroenterologists were concerned about morbidity and mortality for the patient and also post-operative cause and development. And the more evidence we get on specific disorders, I think the more clearer are the guidelines and the ways to move out. And then you will end up with a very small number of patients where there might be a lot of controversy.
So in the future,
in most patients, it's clear. You see, when we discuss now cystic tumors, I think before we were complete different opinions, but now in many cases, I think the gastroenterologist, if you would ask, would not see him, we would say conservative or surgery, and we would also, so it's a minor number where you might think age or comorbidity, whether it's this way or this way.
So would more combined research improve that evidence to cause less causes of friction?
Yeah, we anyway do this combined because most of the patients are seen by both.
I think what we have to learn, and this is also at this congress, is if we fight together against our competitors, the competitors are not the visceral medicine people.
Yeah.
They are outside of visceral medicine. This we often forget. And so we have to join and fight against non-visceral medicine fields because they are our competitors for money, for research money, and for other things.
Here we have another comment where we see maybe there's still some competition between the surgeons and the gastroenterologists. Here some user says, sorry, actually he does not need a surgeon in his endoscopy unit. When he detects a patient with a rectal cancer, he doesn't need a surgeon who will rush into the room and says you will need an operation, because in his unit the gastroenterologist takes the whole lead of this patient, will make the complete staging, will decide what to do, and then finally at the end he will bring the patient to the surgeon. So maybe you can discuss on this idea.
You see, this is always depending on money. I'm telling this. This is depending on money. If this gastroenterologist has to pay for everything and gets no money for this, he would not be interested in doing this. And the same is on the surgical side. And I think this is often a problem of controversy. This is with the interdisciplinary wards. This is who is the owner of the patient.
Yeah.
I'm the owner of the patient, I'm the leader of the patient, I'm the guidance of the patients. I think there is many related on money and resources. And I think this we should overcome.
Yeah, that's right. That's also what other users say. Unfortunately, we don't have the time to read all of them. Another interesting comment is also nurses are a key link between surgeons and physicians. Maybe this is an interesting point, that the patients or the other disciplines in the hospital have another view as perhaps the surgeons and the internal doctors have.
So actually the answer to the question posed by the Facebook live chat would be a clear yes. They need each other.
Oh yeah.
Yes.
Absolutely. It's very easy.
Okay, but that's a very clear answer to a very clear question. And I couldn't agree more. And I would like to thank you both and Ulrich for taking part in this Facebook live chat. And we hope that you still give us interesting comments and feedbacks and questions. And thank you very much.
Thank you.
Thanks.
Thank you. Bye.
Bye-bye.